Hello, my name is Robert Kacinski, and today I'll be presenting on characteristics of flow in the upper airway during high-flow nasal cannula oxygen therapy. I would first like to thank our sponsor, Vapotherm Inc., for providing funding and support for the project. Some quick background. High-flow nasal cannula oxygen therapy is a non-invasive respiratory therapy in which heated and humidified oxygen is delivered via a nasal cannula geometry such as the one pictured on the right. Flow rates of HFNC oxygen therapy are up to 60 liters per minute. High-velocity nasal insufflation is a subset of HFNC oxygen therapy in which the flow is delivered at higher velocities via a modified cannula geometry in which the inner diameter of the prongs are smaller, such as the one shown on the bottom right. 4 therapy conditions were tested. No therapy, which was to be used as a baseline for species metrics comparison. HFNC, which uses a generic HFNC cannula geometry, and HVNI 1 and 2, which use 2 different HVNI cannula geometries. Each of these therapy conditions were tested with the patient mouth open and closed. The mass of CO2 remaining in the airway at the end of the exhalation process was compared to gauge CO2 flush effectiveness for each therapy. This was used as the metric for comparison because it is a strong indicator of the amount of CO2 inhaled by the patient. An unstructured polyhedral meshing workflow is followed, with all meshes being generated using identical parameters. These parameters were set during the validation study. Notice in the bottom left, the cell count table only contains cell counts for 3 meshes, with the no therapy mesh not being listed. This is because the no therapy mesh is contained within the HVNI1 mesh. For all models containing cannula flow, after mesh generation was completed, the cannula cell zone was deleted, creating a dead zone that simulates a solid. For the no therapy model, the cannula cell zone was simply retained in the HVNI1 mesh, and the cannula inlet boundary was changed to internal faces. When CT scans were collected for mesh generation, the patient had an inflamed left nasal passageway. Because of this, 2 sets of meshes were made, one with an inflamed left nasal passageway with an example cross-section shown in the top right, and another with the passageway open to simulate a more generalized patient scenario with an example cross-section contained in the bottom right. All figures shown were collected using models with the inflamed left nasal passageway. However, CO2 metrics will be included at the end that were collected with the opened nasal passageway, and they will be compared to the inflamed. For the airway inlet, inlet is in quotes because it functions as both an inlet and an outlet depending on the moment in the breath curve that the model is currently at. The airway inlet is a temporally varying velocity boundary that controls both the volume flow rate and the species concentrations of flow entering through the base of the trachea. The volume flow rate matches a breath curve that was generated using the ASL 5000 breathing simulator. During the inhalation cycle, volume flow rated averages of the species concentration are calculated and stored. At the end of the inhalation cycle, these volume flow weighted averages are temporally averaged to simulate perfect mixing in the lungs. A predetermined amount of the oxygen is then converted to CO2 to simulate a surrogate of cellular respiration. This is how the CO2 enters the trachea and upper airway that is then used to note CO2 flush. The cannula inlet is a steady input of 100% oxygen at 35 standard liters per minute for each model run. The environment outlet is a pressure outlet with species feedback of 0.21 mole fraction oxygen. This simulates ambient air. Provided are contours of mass fraction CO2 for the no therapy flush model, with red being high CO2 and blue being regions of low CO2. This model was used as a baseline for CO2 comparison for other models. Notice the high concentration of CO2 in the upper airway, and the fact that there's no flush mechanism, which means the peak CO2 contour looks very similar to the end exhale CO2 contour, as there's no cannula flow forcing evacuation of the upper airway. For HFNC, at peak CO2, most of the upper airway is populated with high CO2 flow other than this region directly surrounding the cannula flow. By end exhale, a majority of the high CO2 is flushed, other than small regions in the upper airway that still contain high CO2 flow. This is significantly less high CO2 flow in the airway than with no therapy. For HVNI1, notice that at peak CO2, nearly no expiratory flow infiltrates the upper airway outside of this small stem of moderate CO2 flow that extends just above the trachea. By end exhale, even this small stem is removed from the upper airway, leaving no expiratory flow to infiltrate the upper airway. There are no qualitative differences between HVNI1 and HVNI2, with the same moderate CO2 stem being seen at peak CO2 and the removal of this at end exhale. The plot on the right is showing instantaneous values of the mass of CO2 remaining in the airway throughout a complete breath cycle. Note that peak exhale occurs at a flow time of 0 seconds, and that the blue line is showing volume flow rate and is not used to relate CO2 remaining in the airway for any of the therapy conditions. Notice the time in the breath curve at which peak CO2 concentration occurs for each of the 4 therapy conditions. HVNI1 and HVNI2 show peak CO2 values shortly after peak exhale. After this peak, the flush process begins, and the mass CO2 remaining in the airway only decreases until the end of the exhalation process. For the HFNC therapy condition, there is a considerable amount of time after HVNI hits their peak CO2 values at which the mass CO2 remaining in the airway continues to grow. After the volume flow rate of the expiratory flow reaches a sufficiently low value, HFNC then begins to flush this high CO2 expiratory flow out of the upper airway. The no therapy condition continues to rise in the mass CO2 remaining in the airway until the end of exhale, as expected. Notice the red circle in the bottom right, which is showing the point where HVNI begins outperforming HFNC. The HVNI1 and HVNI2 curves begin to dramatically flatten in comparison to the HFNC curve, which is still rising significantly faster than the two as the mass CO2 remaining in the airway increases. The distinctions are far less noticeable for the closed mouth models. Notice that the no therapy model contains the lowest amount of CO2 in the airway for much of the exhalation process. Just prior to end exhale, the point at which HVNI distinguishes itself from HFNC is circled in red. HVNI begins to flush the airway at this point as the expiratory flow decreases in volume flow rate. However, HVNI barely dips below the no therapy end exhale value, with HFNC remaining above this value because of the presence of the cannula limiting the area for flow to escape the airway. The closed mouth model shows very little distinction in end exhale CO2 and proposed inhaled CO2 values for each of the 4 therapy types. Shown on the right are velocity contours of HVNI1 and HFNC. It is expected that there would be quantitative differences in the velocity profiles between the 2 therapy types. However, there are qualitative differences between the velocity profiles seen in the contours. HVNI1 shows a significantly larger region of high velocity surrounding the cannula. This would be expected and included in the quantitative differences. However, the HFNC model shows the expiratory flow taking over the low velocity cannula flow and creating a local velocity maximum in region 2. This is a qualitative difference, as this point coincides with a local minimum for HVNI. A table containing the results for all 12 models run in this study is shown on the right. For the open mouth cases, there is no difference in HVNI1 and HVNI2 with both an inflamed or opened left nasal passageway. HFNC has over 2 times the amount of CO2 remaining at end exhale when compared to HVNI for an open mouth inflamed case. The inflamed left nasal passageway also affects HFNC flush significantly more than HVNI flush, with HVNI flush for both HVNI1 and HVNI2 showing only a 0.1 milligram increase in CO2 remaining from the opened to the inflamed model, while HFNC shows between a 1.5 and 2 milligram increase from the opened to the inflamed model. The closed mouth scenario appears to be too difficult to flush for all therapy types, with all 4 therapies coming in over the baseline no therapy for an open mouth model. In conclusion, both HVNI1 and HVNI2 outperform HFNC for all tested scenarios. However, the distinction between the two changes significantly with the scenario being tested. For future work, studies are currently being conducted with different mouth opening percentages to investigate the distinction between the 2 therapies for scenarios with varying flush difficulty.